So my name is Gia Yannikis. I am a neonatologist at Beth Israel in Boston, and I am the TCAN Career Development Chair. And it is my pleasure to introduce this panel, which is our inaugural partnership with the Clinical Leaders Group. Basically, the goal of this panel, and then hopefully some programming that will stem from it, is to increase collaboration between TCAN and CLG and hopefully give opportunities for mentorship and for education about different paths in clinical leadership within neonatology. So again, this is really meant to be hopefully the first of many opportunities for engagement between the two groups. To get us started, we'll just have a little bit of an introduction to each of our panelists, and then my colleagues from TCAN will help us to moderate the session. So here we have Priya Vaithanathan, who is a fellow in Cincinnati, and then we have Grant Schaefer, who is the Quality Improvement Chair for TCAN. So just to introduce our panel, Hannah, do you want to start us off?
Sure, I'd love to. I'm Hannah Fisher. I'm so glad you guys are here. I'm the current chair of the Clinical Leaders Group, and I'm a neonatologist in Louisville, Kentucky, at Norton Children's Hospital and University of Louisville. I have been our division's quality improvement director for the last 10 years, and was the first person to hold that role and get to develop it. And then more recently, I've expanded that to a departmental role as vice chair of quality and innovation for the Department of Peds and director of quality improvement research. I'm really excited to share the experience and things I've learned along the way.
Perfect. Jessica, do you want to go next?
Sure thing. Hello, I'm Jessica Davidson, and I am at the University of Utah, which is in a little symbiotic relationship with also Intermountain Healthcare. So I'm actually the medical director for the Intermountain Medical Center, NICU, which is one of the four that our NEOs cover. And for other leadership type things, I was the past chair for the clinical leaders group, and I currently chair the neonatal outcomes committee for the Utah State Quality Collaborative, and then involved in the AAP at the section level as the District 8 representative to the executive committee.
Jeff, would you like to go next?
Sure. Jeff Myers. I am in Rochester, New York, at the University of Rochester, at one of now many Golisano Children's Hospitals. We were the first, but there are now many. I'm an executive committee member on CLG. I served as our medical director of our level 4 NICU here for about 7 years. And then over the last 2.5 years or so, now serve as our associate chief quality officer at the Children's Hospital.
Thank you. Christy?
Hi guys, I'm Christy Lehman. I'm at Boston Children's Hospital. I'm the Associate Medical Director and Director of Quality for our division. And I'm also the co-chair of the statewide perinatal neonatal quality improvement network. And I'm the program director for the Harvard Fellowship. So excited to have this collaboration with TCAN and worked with Gia during her fellowship, so know her well, and happy to talk about careers in clinical leadership.
And last but not least, Jim.
Hi, welcome you all today. My name is Jim Barry. I'm a neonatologist in Colorado. I've been a medical director for 18 years of one of our level 3 NICUs, and I've got a chance to do a lot of unique things, and I'll just list some off quickly. Executive council for the CLG, and been lucky to work with all of these great folks through the years and learning from them. I've also been the vice chair for peer review and quality for our adult hospital. And over the span of a decade, I helped transition our adult hospital from a punitive case review process to a just culture approach. And doing that as a neonatologist in an adult hospital was quite overwhelming and scary at times. And probably and I'm also newborn chair for a 14 hospital system. So kind of overseeing quality and my main goal is to decrease variability that's unnecessary between our nurseries and our NICUs in our system. And then most recently, I've been a founding member of NeoMind AI and now president of NeoMind AI, which is a group of neonatologists, data scientists, clinical informaticists that are working on the kind of the area of AI in our healthcare space and making sure that it's safe, effective, ethical, and unbiased as possible. So I've got an opportunity to have a lot of different leadership roles, and it's been fun. So happy to share with you guys here today.
Thank you all so much. So we do have some prepared questions that we will get started with for our panel, but this is really meant as a resource for our participants. So please feel free to type into the Q&A any questions that come up, either off the bat or as our panelists speak, and we'll be happy to raise those for you. And Priya, go ahead and kick us off.
Yeah, you guys have all such amazing and diverse leadership experience, and so I'd like to start off with some origins. Dr. Fisher, maybe you can start us off with your sort of path to your current leadership role.
Yes. Well, I'll say, I think part of, I guess, my origin story is that when I was in fellowship, a mentor of mine said, you really need to find something that you love to do, that aligns your passions and your goals, and is also something that either our division, if you want to stay here, or another place may want as well. And so I'd had exposure to quality improvement through residency and kind of started down that route and got extra training during fellowship in that, and came back and um, was told by another mentor that now that you carry this, you're really our expert. And so it was interesting to be in that space, feeling like an expert when I was just early on coming on as faculty, but had a lot of support and ran with it in lots of different ways. And I think that that really helped kind of launch me early on into the clinical leadership roles and worked closely with our medical director and such. And so I think, not being scared to jump in, even when you're starting out, can be really important. And having a goal in mind and something to back that up. I think having that early training really helped to kind of set the stage for me to be successful at what I did, but also to give a little bit of kind of credence and backbone to that when we talked about my role as a quality director. And then a few years in, talked about, can we make this an official role? Because at the time, nobody had held that. That wasn't a position that we'd had in our division. But giving a name to it and part of my work assignment to it. And I think that set me up for success and able to kind of broaden that later on.
Amazing. Dr. Davidson, you're sort of next on my list.
Yeah, so I started similar with QI training and QI uh, enthusiasm. And at my first job after fellowship, I think I just maybe had a lot of extra energy to be effective and productive and make friends with people and and get people excited about partnering on initiatives. And I did that for a couple of years at my first job. Um, Unnamed, similar to Hannah again, right? Didn't have a title for that or a role specific responsibility, title. And then I ended up leaving that position and I got to talk a little bit with some of you on the previous webinar about early career transitions. And so about 2.5 years into that role, I switched over to University of Utah and this division and had the same kind of enthusiasm, but again, you kind of start again and use some of those. There was a time where QI training, I sort of felt like the human nature aspect of it made you kind of like a moraler, like a cheerleader for initiatives and for rallying people together. And I think that was the first thing that came easiest to me. So just tried to work on things, find little opportunities in the division, with me being a new member of the division. Um, I will say that is something to throw out there to folks if you're joining a new division, to not come in and try to change first of all, anything, and then secondly, everything. But to learn your new place and then find little opportunities, running little needs assessments in your head, and then maybe starting to have just conversations with people, trying to find places where you can be helpful and where you can support other people's initiatives, and then that can kind of prop you up for being a go-to person to maybe take on fresh ideas. So then I got asked to step into the medical director leadership when a longtime medical director moved on to another position, and I went in there as an assistant to an interim medical director, and that is how I got all the on-the-job training, trained up for a while. And then that interim person left, and then I have been in either co-medical director or sole medical director, or now I'm in a position where I have an assistant medical director, someone who I can like mentor into leadership and have as support too. So, and then the other things I just have gotten into because I love it. Clinical leaders group and working with the AAP and the executive committee is just, that's where I fill my cup with like the networking and learning from all of you and talking to all of you and
It
coming up
sounds
with
like you still have
businesses.
that enthusiasm.
Yeah, I do. I do. I think that it does evolve and you find new aspects of it that are really exciting. Like when you look back and realize that somewhere along the line, like you learned something that you can pass on to someone else. I think that's my new level of excitement about all this.
Nice. And it sounds like QI is the way to go. All right, Dr. Myers, I have you next.
Yeah, okay. So mine's, I don't know, not too dissimilar from others in terms of, I was finishing a fellowship and realized I wanted to stay in academics, but knew for a fact I wasn't interested in all at like pursuing lots of grant funding and being an independent researcher. And while I liked education, I didn't want to focus solely on that as a career path and started thinking like, what else do I like to do? Um, and QI was, for many of us, if you're like kind of my age or older, QI was not a thing that was like widespread and certainly not like it is now. I didn't learn anything about quality improvement in training, medical school, residency, or really even fellowship. And but thought that it might be something I was interested in the little bit of QI that I was exposed to. I also really liked what the medical directors were doing, where I trained and thought, geez, some of this type of work where you get to work with people and teams. Um, I was, played sports for a long time in my life, so loved being a part of teams and teamwork. And QI really fit that uh, passion of mine nicely. I liked the interprofessional nature of quality improvement and liked that you had a real clinical translation with that work. And so it made me think, oh, I want to be a medical director. Uh, and so I came into my job thinking, almost 14 years ago now that I want to be a medical director, but I actually had no idea what a medical director did and what the responsibilities would be. And I had the opportunity to join at a time of need where there was really nobody here doing rigorous quality improvement. And so I filled a void, so to speak, and also really was interested in learning and doing more in the medical director space. And found a good mentor here who was eager and willing to mentor me in some of the roles and responsibilities that the medical director here had. And very quickly found myself as the associate medical director and then eventually medical director. That happened faster than I thought, but was, I think, um, aligned a lot of my own passions uh, with the kind of academic contributions. So yeah, it's how I got to where I am. And then, I'm Associate Chief Quality Officer now. But there's still a lot of quality oversight, and the clinical application remains. So
What sports did you play?
I played baseball in college. I
Nice.
picked up volleyball at the end of high school, and then played that through college and into really through good part of medical school. And I also played basketball.
Very nice. I said because I used to play tennis for my country, and I think I've learned so much on the tennis court that I've translated into like clinical medicine and sort of the life lessons that I've learned on the court, I've been able to translate. So I really understand where you're coming from.
Yeah, my country never asked me to play for them, but I played for my country. They just don't know it.
Correct. All right, Dr. Barry, you're next.
Oh. So I jumped in because I found myself complaining about a lot of issues in our unit. So along with everybody else, we have section meetings that occur about every um, week or every 2 weeks. And people were always complaining about all the issues that were occurring in the unit. And I found that I was also complaining. And then finally, one day I looked at myself and said, well, why don't you go fix some of these problems? So quit complaining and actually go fix them. So at that time, I was doing basic science research, which my section head probably didn't really appreciate when I said, yeah, I'm going to go be medical director of our NICU. I don't think I'm going to do basic science research anymore. And in Colorado, that's a big deal because it's a heavy basic science research section. But I really felt like it was something that I should do. And what I've learned about myself in the last 25 years is I like to fix things. So to boil down to what I do is that I like to fix systems and processes and think about how to make our care better for our patients, for our families, for our nurses, therapists, and so forth, and really have enjoyed that. So it really just came out of frustration and finally deciding, quit complaining and go do something about it. I had absolutely no training in the first several years of being a medical director. I screwed everything up. So we didn't have a quality program, we didn't have case review programs, and I started them from scratch without really any understanding of how to do either. And especially the case reviews, I goofed up because I let things get way too emotional between the people, and I reviewed um, cases that were really emotional and shouldn't have done that to begin with. So, lesson number one, if you're starting a case review program, make sure you start with low-hanging fruit, ones that are pretty vanilla and benign, and that there's easy fixes that everybody will like. So that's kind of how I got into it, was somewhat by mistake, I would say, but it's been a great path for me and I've enjoyed every minute of it.
Very nice. And Dr. Lehman.
It's interesting to hear everyone's origin story. I know you guys, but don't necessarily know your background from that perspective. But I actually also was in basic science and was chugging along. I had a K, like very like things were going well, and I just always have loved clinical medicine and been also into fixing problems, and had this great quality improvement project that I had done during fellowship that really continued on throughout my junior faculty time. And that part of my daily life got me more excited and more excited. And then it was just a matter of like timing where an opportunity opened up, and there was a new role that needed to be filled within our clinical leadership group. And I had to like look inside myself and say, where do I see myself in the long term? And I made that kind of 180 transition, and have not looked back since, because it's been so fun. All the reasons that everyone else has said related to teamwork. And I knew I needed to get more training to do this well. So I did get an IHI improvement advisor training, and have sought out other opportunities to get real kind of foundational training in QI. And I have really loved the mentorship side of building my expertise in QI and being able to teach others how to do QI well, but also have like academic productivity with it. So going up for promotion within the Harvard Medical School is no joke. And so like having real, quantifiable things listed on your CV related to your scholarship, which in QI science is legitimate, but you maybe don't have as many role models that have been able to achieve that. So that's another kind of big piece of what I love to share as far as my journey.
It really sounds like you guys have learned a lot on the job, but also had a lot of great mentors along the way. And then sort of from how you got there to what keeps you there, Dr. Fisher and Dr. Davidson, maybe talking about your favorite elements of your leadership role.
Yeah, I think people talked a lot about some of those that I agree with as well. I think that some of my strengths are I love and really flourish when you're able to be creative and strategically plan and think ahead and problem solve. And so I think that's what these roles bring to me and an outlet for kind of like Jim talked about when there's problems in the unit and you're feeling frustrated. This is a place I can take them and with a team, think outside the box. And I think most physicians have creativity within them. And this is a place where you get to apply that and then see the outcomes and also very data minded, like many of us are as well. And so I think that's what keeps me in QI and the leadership piece of it. Um, I feel really strongly, like Christy said, of helping others learn to do this too. And that brings me some joy and keeps me in it.
And maybe in addition to those things, I'd say the opportunities to keep learning has been, I think it comes about really organically. I don't sit back and say, like, what else can I put on my plate? How can I learn something new? But going from first getting into being a medical director at all, I mean, CLG has done a lot of work on trying to create resources and trying to leverage the publication that Jim put out in 2018, I think, about how medical directors really don't come at this job with a lot of training until they get there, and they just kind of have to trial by fire. Um, and so it's a slightly different landscape now, but it's still tough. And people have to find their way to CLG to be able to use some of the resources that we've tried to create and arm you with. But learning to be medical director, learning how to sort of embody leadership, kind of to have confidence in it and still humility to listen, to see problems, to acknowledge problems, even if you're part of the problem, to acknowledge that and figure out how to heal through or improve through. That's been a growth and a learning process. And then I think even getting into the the next level of work that I've been able to do, like with the Utah Quality Collaborative and with the executive committee for the section, both of those things really keep me in it now because of the new aspects of basically delivery of care that I'm getting exposed to. With the Utah Collaborative, I do a lot with out of hospital births and work a ton with midwives, and that's like a huge. I mean that in Utah, that's a big part of our neonate population. So that's been really cool for me to learn about something new. And with the executive committee, I think just like learning advocacy and learning about payment and learning like the different ways to view our job, our identity as neonatologists within the bigger sphere of pediatrics, and the different ways that we can look at that. That's been really interesting to learn. So I'd say learning things has kept me in it.
Very nice. So, I guess along with those rewarding aspects, leadership inevitably comes with real challenges, like some visible and some less so. Dr. Myers, Dr. Lehman, what are some of the biggest challenges you faced in your role?
That's a good question. I think one of the things that like they don't tell you when you say you'll be the medical director, if you haven't experienced it, realize it, is there's a lot of people management. So as much as you like working with people, I love working with people. Um, we're also a great source of stress and strain on each other sometimes, especially in the NICU environment. Everything is high stakes, stressful, high risk for harm. Uh, it's a traumatic experience for families who we are primarily who we interact with from a patient perspective. And so it is that one was one of the ones that I was not expecting, and maybe should have, but just didn't appreciate the scope of that aspect of the work. Um, and the plus side is I've learned a lot about how to have crucial conversations with people who are 20 years my senior, people who have been doing things a lot longer than I have, across professions, with other leaders, others outside of my division and potentially department. Um, because as medical director, for example, I felt like everything that happened in the NICU, I was in some way responsible for. And I wanted to ensure that everything that happened in that space was geared towards, ensuring the best outcomes for babies and families. And so that meant having difficult and uncomfortable conversations sometimes. But I got to learn how to do that well. I would not know how to do that well, I don't think, had I done something else. This forced me to step outside my own comfort zone, which would have been avoiding those conversations like the plague.
I completely agree with what Jeff said. I feel like that is the biggest challenge is the difficult conversations that are an essential part of the role in clinical leadership. To add to that, I think one of the challenges that my medical director does very, very, very well is when you are in these leadership roles, like empowering your teams to make decisions on their own, and being there to support them and listening and but also like standing behind them when they make a thoughtful decision that has been made, that just empowering people to do the best that they can in every situation and standing behind them, and not that Monday morning quarterback type role, or having people feel that they have to check with you on every single thing, like being there if they need to, but also like if they're thoughtful and like trusting themselves. So like having a culture where people trust themselves and being supportive and being available, but also supporting them in those ways is a big challenge, to have that balance exactly right, where you're available, but also like, people feel empowered to make their own thoughtful decisions. So I think that's one challenge. Another challenge that, again, kind of back to the like academic side of things, is like one little thing. You can have a full day of like all these great meetings for your research and your QI projects and stuff, and one little thing will just take over the whole day. And so just being flexible, and also not allowing your whole like your individual like trajectory in academics to be overpowered by the churn of the NICU every single day. So appropriately, you will be derailed from your schedule and have to deal with things, but you could do that every single day, and having a good sense of, it's a challenge to figure out what to deal with immediately and spend your whole day dealing with, what to maybe put on the back burner and then address in a few hours when you have a break. Those challenges definitely come up. And I remember back, it's a little bit back from when I was chief fellow. I remember this when I was in the basic science lab, like, and Gia can probably answer to this too, is that things would come in and I would just spend the whole day dealing with all of that. And then I'd be like, oh crap, I forgot to do like those cells and that, whatever I was supposed to do because I was so just focused on fixing that problem, dealing with this email that just came in and all of that. So it's important to be available and to be reactive and to address things in real time, but also to find that balance so you don't get overwhelmed by it all.
That's a perfect segue to my next question. Like all of you hold different roles. Um, how do you balance your time as a clinical leader? How do you balance all these different priorities? I'll start off with Dr. Barry. Hopefully you can shed some light on how AI can help to improve that also, and then open it up to the rest of the panel.
Well, so I think for every person, the work-life balance is different, and even different generations. So I would say that your generation of work-life balance is much different than mine when I started 25 years ago. And so it's hard for me to say exactly, but the thing is it, and it kind of fits in a little bit to what Hannah's saying. When you get out of bed each morning, are you excited to go do your job? And so the answer should be yes. And if it isn't, then you should be figuring out what part of your job you're not liking. And if that's the clinical part, if that's some of your leadership. And I wanted to add a few things to like the previous conversation. One thing that people don't know about being a medical director is it's a 24/7 job. So when there's things going wrong in the unit at 3 a.m., you're going to get a phone call. If you're on vacation in Hawaii, you're going to get a phone call. And so that's something people don't really realize, I think. And over time, especially during COVID for me, when I was a medical director in a university NICU, an adult hospital, I spent time working in our kind of stand-up information and resource center that we put together, our command center. And it was constant for like 5 years almost. And that really wore me out. So one thing you have to really pay attention to in terms of work-life balance is that it's not an 8 to 5, 9 to 5 job. It's constant. So right now we're having gaps in our NNP coverage. So every night I'm needing to talk with the NNP leadership, nursing leadership, people who have written contracts to figure out how we can solve some of these problems. And it's never ending. So there's issues that come up. But if you like to be part of solving those, then that's an important part. So I like to do that, like I said, fix things. But you do have to realize as a medical director, maybe it's a little bit different as a quality director, and I'll let the quality directors answer that, is that you're responsible for how the unit functions. You're responsible for how the nurses are working and they're the therapist, the respiratory therapist, the equipment that you have, how you're interacting with OB or your specialist or surgical consults and all those services. So you have a lot of responsibility, but it's actually great. And first of all, like when you're a neonatologist, I was trying to think of how many patients. So when I was a neonatologist taking care of patients, and that's what I was doing, I might have my patient panel of 20 that I care for, and maybe over the course of 2 weeks, that expands to 30 maybe. And I do that, you know, 20 times a month. I get to then take care of whatever that quick math is, 400 patients. As a medical director, I get to help care for 1,000 patients on an annual basis. So I'm helping care for every single patient that's in the unit. And the cool thing is you get to create systems and processes that help your neonatologist and nurses and RTs, and they don't even know you're helping them. So I think the best part of it is you fix things behind the scenes. People don't even realize that outcomes are better, their lives are better because things that you're doing, and you get to be part of that. But it's not an 8 to 5 job. So that's one thing if you're really concerned about working after hours and stuff like that, you do have to consider that because it's a big deal. But if you're willing to do that, there's a lot of rewards for being able to work with teams in particular. And our nursing colleagues are great. They're there for the right reason. They want to make sure babies are taken care of the best they can. And so partnership with nurses in particular is just outstanding. And that's what I like most about my job. So I kind of answered your question. Was there something else you wanted? I was just trying to tell you the truth.
No,
It
yeah.
adds a lot more to your life. But
Yes.
I have found it rewarding and I've done it for 18 years. And if I didn't find it rewarding, I certainly would not have done it for 18 years.
Yeah. Anybody else on trying to balance everything as a clinical leader?
This is something that I feel like I've struggled, and part of the piece that I'm still learning about, and so love to learn from you all as well. Um, but I did a leadership course, and one of the books they had us read was Stephen Covey's Seven Habits of Highly Effective People. And I think what's helped me with that, and this kind of goes to what Christy was talking about, is looking at your work and understanding what is kind of important and gets you to your goal, and you make time for that in some capacity. And then understanding which things are urgent that you kind of have to do now, and deciding and triaging, is this something that disrupts my day or not? And then delegating the things that you can, looking at your plate and what you've taken on. I'm good at saying yes to a lot of things, and I've been practicing looking at that and giving those to other people to give them opportunities, or saying no sometimes, and then which things you can eliminate as well. And so I think that's kind of helped me. Um, be intentional about my time, and also being flexible, knowing that there's going to be days that get derailed. There's going to be days where I have time to work on the stuff I want to work on. I think it is a little bit different probably for medical directors, but you have a team. Like Jim said, you've got, your RT leadership, your nurse leadership, you might have an assistant or associate director. And so I think really leaning into your team, and it sounds like Jeff has some experience to share from their group as well, but that's what's helped me approach this.
Yeah, I think from a balance standpoint, I agree with Jim. I think that can change a little bit, and there might be opportunities because I've had plenty of similar experiences that Jim did. So I think being honest about, like, if something happens at 9 p.m., you might get a call. Um, uh, I think that depending on the situations, it might be a little less frequent. I mean, knock on wood, we're not going to experience another global pandemic. I even hate saying that, but if you were a medical director or clinical leader during that, you understood the stress. I mean, that added probably an extra handful of years to everyone's time as a clinical leader. I know it did to me, and that was okay because of the rewards of the work that we did. I think if you know yourself and you know what your priorities are, like Hannah and Jim already said those things really well. Like it, I was still able to do things that I didn't think I would. Like I still helped coach my daughter's travel softball team for a few years. I never thought I would get a chance to do that, let alone have time and make it to most of the practices and games. And I was able to. Um, and that worked. I mean, this is like one example of, I think if you know how to balance that and what those priorities are, and knowing what you will need to say no to. And that isn't like a no to a thing I want to do in my personal life or no to my family. That's also no to professional things. Sorry, I can't go to that conference. I'm sorry, I can't help chair that committee. Or we don't have the bandwidth to carry out that improvement project in our unit right now. So yeah, we'll add it to the list, but it's not happening. Like sometimes that's the reality. Like you just have to learn how to navigate those types of things. But again, like I learned how to prioritize through this role, learned how to better prioritize, navigate, and keep myself organized in the uncertainty of what the day to day brought. Because as Christy mentioned, like you can have all the plans you want for the day and something will happen and boom, right? When we had the TPN and amino acid shortage, like in like 2017-ish, that was like crazy. And like for like a week and a half, I did almost nothing but try to figure out how we were gonna get good nutrition to our babies. So
But yeah, I wanted to add too, that uh, the I was trying to remember. I remember what I want to say, but I couldn't remember the question that prompted this. But anyway, I think naming the anxiety as anxiety that kind of prompts us to all want to fill our plates a little bit more can be helpful. And then I think also giving grace and permission to mm, this talk is about leadership, right? So if you're in some kind of leadership position, it probably takes up a lot of your time, your administrative time, your academic time. Um, and if we're just talking about leadership of a small group or a small project, then as the time relates to that group or project, being the leader takes up a lot of that time. I think acknowledging that, like telling yourself you're doing a good job goes a long way to like the agency, the authority, like staying in your own authority to say like actually what I'm doing is really meaningful to this work, whether it's to leading this unit, leading this division, leading this project. The role of a leader is an important one, and I don't need to overcompensate by taking on other projects. And I think that's a skill. And I think that I personally have recognized in the last um, handful of years and just the way that life has changed for me and how I want to be doing things that I find rewarding. And then when I'm not doing that work, I want to be spending it with my kids or taking pictures of zebras in Africa. And so that allows me to just have boundaries with work time that I feel good about and then out of work time that I feel good about.
Perfect.
I was just going to add one quick thing. I just learned from Jessica. Thank you for that advice. But when you start saying yes to things, you also should get rid of other things because like you find yourself at 1.4 FTE while you're 1.0 person. Like you can do that for a little bit, but you have to have a plan of how to transition out of other roles, which is advice to I need to listen to myself. And then the other quick thing I wanted to share was about efficiency of meetings. I learned a lot about this and like, do you really need a full hour for every one of these meetings you're booking? Like, can you make them 25 minutes? Can you make them 45 minutes? Like, how can you get some like email catch up time in between meetings and really thinking like, the efficiency of getting what you'll fill the full time with your group. So like, can you shorten everything and just be a little more efficient? And that helps work life balance because if you're going to be able to get more done in a shorter period of time, you have more life time instead of work time.
Yeah, no, that's absolutely right. And what has sort of struck me is that, many leadership stories have key people who have opened doors for you, given guidance, or advocated behind the scenes. And Dr. Barry brought this up in knowing what the difference is between a coach, a mentor, and a sponsor. And I think my follow-up question with that is your own reflections of the people that have helped you in your journey. Dr. Barry's on the phone. No worries. This is how he's trying to.
Coach, mentor, sponsor.
Yes.
Uh, I view a mentor as like a without boundaries and without like limits in terms of like how long that exists for. A lot of us will have. I know I've had mentors for seasons, but most of my mentors, and there aren't very many of them, but most of them I would consider kind of lifelong mentors. And oftentimes these are people who've gone before you, who've done that thing, who've walked that path, who've made it to the other side or navigated that transition. And what did that look like? And how did you do that? I think a coach is like a specific, they're helping you with specific tasks or skills, right? You're right, like, a QI coach is a good example. And many of us have served as like a QI coach, right? We're coaching about like quality improvement methodology, for example. And you may have, there are communication coaches. There are, all different kinds of coaches that might exist. I don't know, a sponsor. I wear too much of a QI lens, so I'm just thinking about like a sponsor for like a QI project.
It's
Might be someone who's in leadership, maybe someone like your division chief or department chair. Jim's shaking his head no, but like,
Not your division chief, maybe your department chair. It's basically somebody when the door closes is going to stick up for you and say that you should get the job. And it can't really be your section head because they're always looking out for you to promote your career. And it really has to be somebody within the organization that's in a kind of a position of power that when there's closed doors conversation is somebody who sticks up for you. Those are probably the hardest to actually find. And so sometimes you actually have to go search them out. And maybe it's a chief quality officer. So there's probably people, Jeff, that probably view you as their sponsor. So now that you have a leadership position within the organization, people probably are coming to you and saying, hey, if there's a job becoming available, I'm interested in doing this. If you hear of anything, can you let me know? And in that closed room, you're actually advocating for that person. So a sponsor is really important for advancing your career, but I think out of mentors and coaches, they're kind of the hardest to find. So you actually have to go search them out yourself. And when you're early is as a fellow or early junior faculty, it's probably not as important to do that until you get established a little bit, kind of understanding where your career path is going to take you or what you want to do, and making sure that you develop some of those connections. So section head, not so much because people won't respect what a section head says about you as much because all section heads are supposed to be supporting their team to improve and kind of move on in their career. So you kind of already you're outside of the sponsor category.
Very interesting. I think this applies more in like the corporate role, but like trying to understand how it fits into like a leadership role is also very important. And I sort of want to end off, and I know we have very little time for Q&A, but like advice for fellow and early career neonatologists and starting
Learn
off.
AI. Wasn't I
Oh,
supposed to say
perfect.
that already?
Yes. No, you
So
didn't.
Notebook LM, that's your friend. If you haven't started using
Yes.
Notebook LM, you're not being as efficient as you could be.
Um, my advice for fellows and junior faculty that really want to get into clinical leadership is to take on something within your unit. So there might not be an open like role because everything's all filled or whatever, but if there's, someone needs to take on transports or someone needs to take on whatever it is, some little piece, volunteer, take that on, or a new clinical guideline, something as simple as that, like in your area of expertise, like I'm going to take on the new guideline for X, Y, or Z, and build those relationships with the multidisciplinary team and the nurses and outside of the clinical world, but in this additional part. And I think just showing your passion and energy and then relaying that to the team that's there, and just by you'll learn a lot from it, but also people will notice and tap you for other opportunities as they come up. And then I do think, as kind of Hannah's a good example of, is like as you start doing things, if you're really filling a void and filling a role, also ask for like, I'm doing all this work as the transport person. Like, is there an opportunity for a title and maybe some clinical time related? And that might not be possible yet, but at least you're showing your interest in being part of the leadership team and being vocal when things come up at faculty meetings and just really sharing your experience. And I think all of that builds your brand as someone who is helpful and effective in these roles. And as opportunities come up, you'll be thought of for those.
And I might add too, just think about when you reach out to someone. Um, I think I'm confusing my comment with the Q&A stuff too, but when you reach out to someone who's in a leadership role, like Christy was saying, maybe the transport person because you have a transport issue, and you get a response for them that might say something like, I'm out of town right now, but let me get my dyad nursing partner to answer your question or something. You don't think twice about that. You're not like judging that person, like, how could they not handle my concern right now? You're like, cool, good job. Someone's going to be on it for me. So as you're in a leadership role, if there is ever that situation, maybe you're coding someone at the moment and someone's like calling to tell you that there's a leak in the ceiling of your unit or something. These things happen. You can say, I'm busy at the moment. Let me get my nurse manager to give you a call back or my associate medical director or something. And that's reasonable too.
And Dr. Fisher, you had something to say.
I think start to really think about what your strengths are and what you enjoy doing, and follow that, but also start to surround yourself with people that complement your strengths, and make you've all been part of those teams that you work better because you're a team, and you've probably also been on teams that haven't been as effective, but really thinking about that intentionally, and kind of like Christy said, communicate when you do great things, communicate about what you want in your future. And that's how I think you start to develop those relationships, and also potentially that point of a sponsor. If people know that you've been effective in the past, that you have these strengths and what your goals are, then they can better speak about you in the room that you may not be in, but that helps launch you into your next phase.
Thank you. Grant, I'm going to hand over to you for some Q&A, and to wrap up our panel discussion.
Alrighty, thank you so much, everyone. So a whole bunch of questions direct message to me. I'm going to summarize a few of them so we can try to get through as many as we can. One question that came up from several different people, I think, is something that many graduating fellows and early career neonatologists feel is, so how early is too early? And specifically in the context of leadership, a few people message that they've seen people very, very junior get put into positions, and sometimes it seems like without quite the support to really be effective. So one, how early is too early? And two, what might be a good way for people to judge how much support they may be getting into the role and how that may play into kind of some of the initial discussions when they're discussing, accepting, and then negotiating what that might entail. And I'll open this one up to the group if anyone has any thoughts or.
So I was also sort of answering this question in the Q&A. So you were asking about being a bit junior to be into a leadership position, and that definitely happened with me. I came out here 2.5 years in, and then stepped into the medical director role in some version of it when I was about 4 years out. Um, I I just you can't sort of overestimate talking to people and talking to the right people. So number one, talking to your actual division chief, just talking to them about being junior and about what the expectations are and what resources they might recommend or who they might suggest as a mentor. And then talking to people that you can that fall into more organic mentorship positions. Like for me, I had like Jim and Munish, and Mike and Jeff, but I mean, being able to meet with and talk to you guys as often as I did in the beginning of my leadership role, I just gained so much. And there were so many times we'd have a CLG meeting. And then as we'd finish our CLG work, I'd say, okay, can I hold you guys and ask a question about like some issue I'm trying to deal with in my leadership? And so having people to talk to can sort of help get past that junior thing. If you're tapped as a junior, someone sees some strength in you, um, and that's okay. And if you have imposter syndrome issues, then you can work that out on your own because we all do. And then, but if you have people to talk to about it, I think you can kind of um, uh, you can grow into that role, and that's a good way to come into leadership. Um, and I want to speak to this thing that I was just answering on the Q&A. I was answering that question about differentiating between the title of lead versus medical director and how much to push for that at an early stage of your career. And I think my answer is just the same thing. Like, I think talk to people, and I think talk to your division chief and even ask that question and say, it feels like I'm kind of leading this. What are the criteria? Where does this cross the line into being the director of this program? I would also encourage that person to reference maybe the CLG workshop that we had on differentiating a QI initiative from a program, because clinical programs are a bit more comprehensive, more robust. There are guidelines within a clinical program, and different metrics within a clinical program versus an initiative or a guideline. And if you're leading an initiative, that's great, but you're not like you don't want to ask to be, can I be the director, the medical director of hypoglycemia management? No, like we'll just write a good guideline and lead that initiative. But you want to be the director of, like the ECMO program, that's a little different. That's a little more comprehensive. Quick shout out to the differences there.
Yeah, that's very helpful. Another group of questions that came in, and I know we're getting starting to get short on time, so this may end up being our last one, but has to do with specifically organizational leadership. And I think, for many of us, we are pretty comfortable interacting with the NICU and the NICU structure. How our organization structures itself may vary. It's kind of a black box for many people. So, any suggestions or advice for people, particularly one person said that they're transitioning, it sounds like, into some kind of role at their organization and they don't know how their organization is structured. Any good questions people can be asking or advice that you guys might have about how they could approach that? I think specifically in the context of how to figure out who does what within the organization outside of the NICU.
Sometimes you can simply ask for an org chart, and that actually helps kind of understand who's reporting to who and kind of what team that you're following under. I would say most big organizations have that. Other smaller ones, maybe not so much. But figuring out if whatever role you're in or being asked to be on or committee, understanding the reporting structure for that committee is important. Potentially who's reporting to you and what the roles of that committee or leadership position is, and then who are you reporting to? And that's pretty helpful. And when you're in the quality or medical director role, that's usually chief quality officer of a hospital, a CMO, depending on how things are set up. But asking those questions up front. And the one thing is, I think in medicine, especially when we get put in these positions, we're sometimes too bashful. Ask as many questions as you can until you get the answer. So for you to be an effective leader, you really have to understand who you're working with, what your role is, what the actual goal and or job description is that you're doing. And if you haven't been given a job description, really ask for one and say, I need on paper for you to tell me what I'm supposed to be doing so that at the end of the year, I know if I've been effective or not. So another way to do this, and I've done this in roles, is when there hasn't been a great job description and I'm talking with a leader who's putting me in that position, I ask them, so it's a year later, how have I been effective in my role? What have I done that have made this role positive and outcomes good or whatever you're looking for? And you just have to keep pushing sometimes.
Fantastic. Thank you so much. That I think I got a text that directly answered the question they were asking, so very appreciated. So with that, I want to be respectful of everyone's time. We're at one past the hour. Thank you so much to all of our CLG mentors for joining today and for sharing all your wisdom with us. For the TCAN people on the call, we are hoping Gia will be kind of forwarding some things to kind of push this work and help formalize some aspects of it. So there will be a needs assessment coming out to the group to kind of make sure that we're being thoughtful about how we're structuring this. And then the goal is to hopefully have some formalized mentorship structures too. Very appreciative to CLG for their willingness to partner on this and very excited for future events with it. But again, some more things to come with it. We wanted to get the ball rolling for today. Anything else, Gia?
Thank you everyone for joining.
Thank
Thank
you.
you.
Thanks, everybody.